Well, my next talk is colorectal emergencies from the ICU. No financial disclosures. We get called by the ICU intensivists when they presume the colon and rectum to be the cause of critical illness. I put this slide up there because fortunately I very rarely have to second guess them, but if you need to know your colleagues. If that is a question, if you're not sure, then first you have to make sure that they're calling you for the right reasons. The typical colorectal consults from the ICU are bleeding, toxic megacolon from any cause, ischemic colitis, perforation, and other zebras. I find ischemic colitis to be the indication where you need maximum judgment and restraint, and there's a lot of chances of making an error. At least for me, I've found ischemic colitis to be something which flummoxes me at least once or twice. First steps whenever I get an ICU consult is to risk stratify the patient and find out their prognosis. If they have a million diseases and they're probably gonna not survive for long, that needs to be taken into account before we jump into operating or doing something invasive. We have to define goals of care along with the family and the ICU staff. We have to have a multidisciplinary meeting up front so that 3 days after you do a big operation, the critical care attending doesn't pull the plug saying, oh, I don't think this patient is going to make it. So that has to be done up front. Everybody needs to be on the same page before we do anything further. Surgical principles are, it's important to do what is life-saving. It is not necessary to pursue definitive treatment at the get-go. Choose the fastest and safest option for the patient. Do not hesitate to divert. I've seen seasoned surgeons making the mistake of making a connection for a critically ill patient. Bleeding is typically very straightforward. By the time the surgeon is involved, gastroenterologists have worked the patient up. The goal is to localize and treat. The options to treat are via endoscopy, which is colonoscopy, via angiogram and embolization, or surgery. Because it is quite an extensive topic, I'm just going to touch upon things which I think are useful to us today and not go into an extensive discussion of every topic. So these are high-risk features for patients who have bleeding. It is an ominous sign if a patient is admitted for something else and starts bleeding from the lower